Hello, assalamu alaikum, guys. My dear doctors, assalamu alaikum. Today I am going to discuss about a long case which is about renal cell carcinoma. In the post graduation exam in the MCPS and FCPS part 2, this long case is one of the very common malignancy long case which is a part of urology department, but in case of general surgery you have to encounter these long case sometimes. Okay, so let's start. So first you have to present your case within 10 minutes at least. Like my patient, Mr. X, 55 years old, businessman, hypertensive, non-diabetic, hailing from Shojonkanda, Rajbari, presented with presence of swelling in the left side of the abdomen for 6 months and pain in the left side of the abdomen for 6 months. Passage of blood in the urine for 2 months, and according to the patient's statement, he is presenting complaints started about 6 months back. Then he noticed a swelling in the left side of the abdomen which is gradually increasing in size, and he also complains of pain in the left side of the abdomen for same duration, that is fixed, constant and dull-lacking in nature. No aggravating or relieving factors, no relieved even after taking analgesics. He also noticed passage of blood in the urine for last 2 months, that is painless, episodic, and total occurred 2 to 3 occasions, continued for 2 to 3 days. So which is relieved spontaneously. He has no history of passage of clot or fleshy materials or retention of urine. He gives no history of evening rise of temperature, loss of appetite and significant weight loss, fever and chills and rigor, any renal trauma, bleeding disorders or taking drugs or food that make the urine colorful. His bowel habit is normal. So he has no history of cough, hemoptysis, chest pain, bone pain or jaundice. He is hypertensive for 15 years, takes antihypertensive medications and occasional analgesics for relief of pain. Otherwise, no significant past medical or surgical history. He has no history of allergy to any foods or drugs. He is immunized, married, having 2 children, all are healthy. He belongs to middle class family. He is smoker, taking 15 sticks per day, which is a very important findings here. And for last 20 years he is a non-alcoholic and non-betel nut chewer. On examination he is mildly anemic, not ecteric, nutritional status is average, and all other vital signs are within the normal limit. Left renal angle is tender. On abdominal examination you don't want to mention that you are explaining about abdominal examination, just keep it continued. Like left renal angle is tender, left kidney is enlarged in size, measuring near about 15 to 10 cm, elongated, reniform in shape, firm in consistency, smooth surface, well-defined margin, upper limit cannot be felt, and but finger can be insinuated under the left costal margin. Moves with respiration, free from underlying skin and underlying structures. The right kidney is normal. The liver and spleen is not palpable. No other organomegaly, no ascites, bowel sound is present, and digital rectal examinations and other systemic reveals no abnormality. So what is your diagnosis here? So left renal mass, possibly renal cell carcinoma. So what are the other possibilities? That depends on your history, that is unilateral polycystic kidney disease, hydronephrosis and retroperitoneal tumor. Why it is a case of renal cell carcinoma? This 55 years old smoker presents with classical triad of presentation of renal cell carcinoma, like low in pain, low in mass and hematuria. These 3 things is a very classical symptoms. Is it possible that patient presents with low in mass in case of TCC of upper renal tract or renal pelvis? Yes, it is possible when the tumor obstructs the renal pelvis and resulting in hydronephrosis. Now, what are the investigations? So firstly, ultrasonogram of the whole abdomen with special attention to kidney, ureter and bladder region. that is size of the lump, origin of the lump, extension of the lump, solid or cystic in nature, lymph node status, any evidence of metastasis, and urine for RME or culture and sensitivity, serum urine, intravenous urography, anatomical delineation of pelvic LSL system. So we by IVU we can see the anatomical delineation here, and pelvic LSL system and excretory function of both kidney. In case of CT scan, it is a gold standard for diagnosis of mass of the kidney, like a better delineation of size, origin, extension of the lump, lymph node involvement. Contrast enhanced CT provides accurate information for renal vein and IVC involvement. So MRI of the abdomen includes vascular invasion is better delineated with MRI. So chest X-ray, CT chest, any evidence of lung metastasis like cannonball appearance, and bone scan if the patient is symptomatic to see any evidence of bone metastasis. Echocardiogram if CT scan shows IVC involvement, in that case we will go for echo, because the tumor embolus can be transferred through infravena cava to the heart and thorough minor vessel. In that case heart cardiac arrest can be happened, or it could be mimicking features like atrial myxoma like features, or sometimes this tumor embolus can obstruct the valvular gateway. That's why echocardiogram is necessary. And as you know that kidney tumor is a osteolytic lesion happens, so it usually transferred to the vertebra or bones. In that case bone scan is necessary. And in case of chest, you will see in the lung as a cannonball appearance, that is metastatic features of renal cell carcinoma. So before operation, DTPA renogram should be done to see any split renal function. So here DTPA is used for existing renal function presence or not. To see that functions, we need to go for DTPA. And other investigations for fitness for patients like anesthetic fitness, like hemodynamic status, okay, and nutritional status also. Is there any role of FNAC or core biopsy to confirm the diagnosis? Carcinoma of the kidney is diagnosed on clinical ground and form the radiological findings. So FNAC or core biopsy is not indicated here. It will breach the capsule and may cause of tumor cell along with the needle tract. So FNAC and core biopsy is not needed here, because it will infiltrate the capsules and tumor cells can come through and spread to the other sides. Is there any role of renal angiography? With the evidence of good quality of CT scan, the renal angiography is not a routine investigation for evaluation of carcinoma of the kidney. So with the evidence of good quality CT scan, the renal angiography is not a routine investigations. Okay, it is primarily reserved for the patients with bilateral renal tumor or patients with solitary kidney to gain knowledge of vascular anatomy for planning of nephron sparing surgery. So renal angiography is spared or keep it reserved due to if bilateral renal tumor. So we need to know the vascular anatomy for planning of the nephron sparing surgery. That's why renal angiography is sometimes done. So it is not usually done, but in case of bilateral renal tumor, it is done actually. So now the staging, you must know the staging of RCC, because in the exam, in the Viva exam, you will encounter this question, because sometimes your teacher can ask, can you tell me what stages this specimen is? Okay, so Robson staging is a common staging. The stage 1, tumor is confined within the renal capsule. Stage 2, tumor involves the perinephric fat but confined within the gyrotous fascia. And stage 3 tumor involves the renal vein, inferior vena cava. Tumor involves the regional lymph node. Tumor involves both renal vein and the regional lymph node. And stage 4, that is, involves the adjacent organ other than adrenal gland and distant metastasis. So AGCC staging, that is T or no evidence of tumor, TX, T1 tumor less than 7 centimeter and confined to the kidney. T2 more than 7 centimeter confined to kidney. T3A extends to perinephric tissue, adrenal gland, but area in the gyrotous fascia. T3B involves renal vein or in the inferior vena cava, and T3C involves renal vein, inferior vena cava above the diaphragm. That means already this tumor extend to the heart. And T4 invades adjacent tissue beyond the gyrotous fascia. Regional lymph node, NO means no lymph node metastasis. N1, a single regional lymph node is involved and into more than one node. Distant metastasis, MO, no distant metastasis. M1, distant metastasis happened. And clinical staging, early localized tumor or not, and advanced tumor present or not. So this is the staging. You must know what happened in each stages. So because sometimes in the exam you will have your staging, but if you answer the questions you will have a better mark or maybe pass in that stage. How will you treat this case? So treatment depends on your case history. Treatment options for all stages of disease are stated below. This patient should be managed by multidisciplinary team approach. You must, before explaining any treatment of a malignant disease, you must say, I will discuss the whole subjects with multidisciplinary team approach. Then I will counsel the patients about prognosis, treatment protocol, and outcome and cost efficiency about the treatment process. Then treatment depends on the stage of the surgery, like fitness of the patient, availability of the facility, informed written consent should be taken, and surgery is the only effective and curative treatment here. And this tumor is usually radio resistant and is insensitive to chemotherapy, right? Because you must know it is a radio resistant tumor and the insensitive chemotherapy, so surgery is the only options. Okay, now treatment according to the staging. So in case of stage 1 tumor within the renal capsules, or nephrectomy is the treatment of choice. In case of stage 2, tumor involves perinephric fat but confined with the gyrotous fascia, so including adrenal gland. Stage 1, stage 2 localized tumor, that means. So radical nephrectomy, en bloc removal of the kidney, and it's involving the fascia, including the ipsilateral adrenal proximal 1/2 of the ureter and the lymph node up to the area of the transection of the renal vessels. And the minimally invasive surgical approach is a percutaneous cryoablation of localized RCC under the USG or CT guided are performed in the some center recently. That means minimally invasive techniques. And the nephron sparing surgery, that is inoculation, wedge resection of resection or the partial nephrectomy for localized and polar surgery. And I think nephron sparing surgery is most trending nowadays. And most of the exam your teacher will ask, can you justify this specimen is for, because it is not so intense, so is it good to make the whole complete nephrectomy or nephron sparing surgery? So you must explain how or why you will perform nephron sparing surgery and why not you go for total nephrectomy. Okay, so stage 3 locally advanced tumor, and tumor involves the renal vein, IVC, and also the regional lymph node. In that case, radical nephrectomy with removal of thrombus with the presence of vascular and cardiac surgeon. In that case, you must have cardiac and vascular surgeon beside you, because you must open your renal vein or you must explore IVC. That's why vascular surgeon is necessary here. Stage 4 or a metastatic tumor treatment is a palliative nephrectomy, and the resection of primary and secondary lesion may prolong the survival. And the palliative nephrectomy for control of intractable hematuria and hormone production and paraneoplastic syndrome. Now the options here: nephrectomy, immunotherapy, gold standard nowadays is the hormone therapy, progesterone, tamoxifen, interferon therapy, immunotherapy, autolymphatic therapy, and anti-CD3, chemotherapy, radiotherapy, surgery is bilateral renal. In case of bilateral renal cell carcinoma, surgery, bilateral nephron sparing surgery, radical nephrectomy in one side and partial nephrectomy to other sides, and bilateral radical nephrectomy and hemodialysis program. Then after 2 years, renal transplant may be performed if no metastasis is seen within this period. And the bench surgery, auto transplantation in one side or both sides. Follow up: no universal protocol, there is no follow up because most of the patients die within 1 to 2 years. But if it's very early, stage 1, stage 2, in that case, if radical surgery happens, so 3 monthly for first year, then yearly one time. And prognosis depends on stage of the disease. Removal of even large neoplasm may be curative. In operative case, 5-year survival rate is about 60%. So you know most of the patient is not going to survive because maximum patient comes lately. So golden period of time is already passed. So up 5-year survival rate ratio become 60% here. So radical nephrectomy performed in which stage? Stage 3. Okay, so stage 1 and 2 is for nephron sparing surgery. So what is radical nephrectomy? So classic radical nephrectomy consists of removal of the kidney, renal fat, adrenal gland, and regional lymph node. And however, in the patient with a tumor less than 5 cm in size located in the inferior pole, the adrenal gland can be spared because adrenal gland is separated by a capsule, and both adrenal gland and the kidney is separated. So we can excise the tumor because tumor is not in the upper pole but in the lower pole. So we can spare adrenal gland. What are the indications of partial nephrectomy? Partial nephrectomy is indicated for the patients with a T1 tumor and the normal contralateral kidney. Moreover, a partial nephrectomy is strong recommended in the patient with RCC who have only one kidney. Also in those with bilateral synchronous RCC or renal cell carcinoma, and in those with von Hippel-Lindau syndrome. It is one of the important immunological disease which is happening in the kidney and which is mimicking as renal cell carcinoma. What is nephron sparing surgery? It means inoculation of wedge resection of inoculation, wedge resection, or partial nephrectomy. It can be performed for localized or polar tumor. Okay. If there is extension of tumor into the renal vein or the inferior vena cava, how will you manage the case? So renal cell carcinoma may extend into the renal vein or the inferior vena cava up to the right atrium of the heart. If the tumor extension into the renal vein, only the renal vein should be ligated proximal to the site of tumor extension. If the tumor extension into the vena cava, the inferior vena cava should be dissected by long venotomy and removal of the tumor to proximal control of vena cava. I already told you that a vascular surgeon will be present during this operation, so he will progress like this way. So if tumor extension to the right atrium, then with the help of cardiac surgeon, tumor cell should be removed from right atrium and vena cava under cardiopulmonary bypass. Now, what are the etiological factors of renal cell carcinoma? So the cause is not known, but there are some factors like dietary factors, environmental factors, chromosomal abnormality, oncogenic defect, adult polycystic kidney disease, then analgesics abuse, and also the smoking. What are the subtype of renal cell carcinoma? So clear cell renal cell carcinoma, papillary renal cell carcinoma, chromophobe renal cell carcinoma, clear cell variety is the most common one. Okay. What are the macroscopic findings of RCC? So macroscopic cut surface of clear cell renal cell carcinoma is a golden yellow in color with frequent hemorrhagic, necrotic and cystic area. The tumor arises from one pole, most commonly upper pole, and hemorrhagic due to invasion of vessels, and necrosis due to ischemia, and golden yellow color due to deposition of fat. So here you can see a massive hemorrhagic invasion and necrosis present in the ischemia, and the golden yellow color deposition due to the fat. And the macroscopic cut surface of clear cell carcinoma is a golden yellow in color with frequent hemorrhagic necrotic areas. So yes, this question is asked in the viva, because in the specimen your teacher will explain you, can you tell me what is the macroscopic findings here, or architectural definition of this lesion. So you will go for this answer, that is macroscopic cut surface, which is, as a clear cell is more common, so you will explain the renal cell, clear cell renal cell carcinoma is a golden yellow in color with frequent hemorrhagic and necrotic and cystic area. What are the microscopic features of RCC? Microscopically, clear cell renal cell carcinoma usually consists of tumor cell with clear cytoplasm arranged in a nest or tubules surrounded by a rich vascular network. Okay. Why it is mixed adenocarcinoma? It is a mixed adenocarcinoma because it contains three type of cell. One is glial cell and granular cell. Okay, thank you very much. That is all about today's lecture. I hope this long case will help you, because most of the question answer is covered here. So in the long case you have to explain your salient feature very clearly, then you have to give some question like diagnosis, possibilities, investigation, treatment and other factors, and also some important things happen, like staging actually. So and according to the staging treatment. So this things is a very concise things. Before going to exam, please repeat the video again and again, and please like and subscribe my channels, and it will give me much more encouragement for the future video making. Thank you very much. Fees.